hyperabsorbers of bad fat. Now, you can't absorb fat that you don't eat, so you teach your patients, even though these markers look rough, if they don't eat fat, it will have no effect on them whatsoever. But if they do eat fat, fried food, butter, mayonnaise, things that have saturated fat issues in it, red meat, they're going to absorb fat and soak it up like a sponge. And so it will have significant bearings. If there's a problem with this patient in fat absorption, you may want to consider a blocker like Zetia or Welchol plant sterols. This particular patient's ApoB and LDLP are both normal. Thus, the patient's statin is working to block the synthesis. They're hyperabsorbers, but apparently not eating a lot of bad fat. This particular patient would not need to be put on a blocker. Now, if you look at this patient, the sterol synthesis marker showing the liver synthesis product is again controlled by the statin. The top rectangle is showing that this particular patient is having some problems with overabsorption. Now go to the rectangle next to that and you see a trend analysis. Over about 2 years, this patient had decent control 2 years ago with the bad fat, but you see the trend is going upwards in the wrong direction. Now you've got the LDLP above the 900 that your goal is set for. You've got your ApoB above the 50 that's set for. This would be a patient that might benefit from placement on a blocker, Zetia, Welchol, or a plant sterol. Lp(a). I hear a lot of confusion about Lp(a), and I hope to clear up this process as we discuss this now. Lp(a) is an LDL-like lipoprotein that has a connecting peptide that makes it highly atherogenic. It becomes a real problem in men at all ages. It becomes a problem in women when they lose their estrogen-containing production or the estrogen supplementation by hormone replacement therapy. There are variations in how this particular Lp(a) comes together, and thus ethnic changes are noted as far as the size of these Lp(a) particles. And it's very important that you understand this ethnicity changes because it will affect your treatment decisions. If you look at this top rectangle up here with Lp(a) mass and Lp(a) particle measurement, you notice everything is in the green and the particle was not even tested because there was no reason to reflex test the particle when the mass is normal. When the mass is normal, the particle number is always normal. In the case of this second case here with Lp(a) mass being in the red and Lp(a) being in the green, now you've got a patient that could very well be of Indian descent, Asian descent, and African American descent. And these particular patients sometimes show up with large mass forms that don't require treatment. You base your treatment decisions on the particle number. If the Lp(a) particle number is good, it doesn't matter what the mass is. This patient does not require treatment. But now on the bottom rectangle here, you see an Lp(a) mass that's significantly elevated, and an Lp(a) particle that's also significantly elevated. This patient requires treatment. It doesn't matter what their ethnicity is, and thus that'll help you settle some of the confusions of treatment. Now, the treatment for Lp(a), the only thing that we've found that works well is niacin. The best form of niacin that I found is treatment with niaspan. There have been some confusion about niacin and niaspan in the recent studies with AIM-HIGH and the THRIVE trial, and these were looking at different forms of treatment. Take it back to Lp(a) as the reason you're treating. If you have a patient with high levels of Lp(a), what else can you treat these patients with other than niacin? The answer is nothing. Therefore, niaspan becomes a major form of treatment for this particular problem. The THRIVE trial was looking at patients with LDLs that were just slightly elevated and triglycerides that were minimally elevated. Different problem. Didn't show the statistical significance that we wanted, but it was not an Lp(a) issue. The AIM-HIGH trial was also different and looking at different processes, and it also allowed patients that had been on niacin to be continued on the trial after a 1 month washout. I want to encourage you when you see a patient with marked elevations of LP, little a particle number, that you treat these patients with niacin, getting them down to a reasonable level if they can tolerate it. If you're going to use niacin, though, you've got to know, don't mix it with hot foods, don't mix it with spicy foods, don't mix it with alcohol. If there's been alcohol in the system, you need to wait 3 hours before you take the niacin. If they take some form of pectin, especially modified citrus pectin, you not only help block some of the prostaglandin response that causes some of this flushing, you also provide some barrier that may improve a stiffening process in the heart that occurs from so many of our cardiovascular patients with circulating inflammation. When you give niacin the correct way, the amount of flushing is very minimal. You start with 1 a day at bedtime for about 2 weeks, then you go up to 2 a day at bedtime with the 500 milligram niacin. And then remember to make sure they get that modified citrus pectin. Now, modified citrus pectin usually comes in a 600 milligram form that you can take 1 to 2 of twice a day. If their problem with galectin-3 is under 20, their level is under 20, I only use 1 twice a day. If it's above 20, I use 2 modified citrus pectin tablets twice per day. But always giving the 2 right before the niacin if the patient is taking niacin. It works very effectively, and you have very little carbs tied in with that process. Now let's talk about inflammatory disease. Rheumatoid arthritis, lupus patients, even ulcerative colitis and Crohn's patients are known to have higher levels of cardiovascular events. It stands to reason these are inflammatory properties. You've got an autoimmune attack that's creating an inflammatory environment. That inflammation is certainly going to get into the blood vessels. Your goal is to turn that disease into a remission state. To do that, you've got to use disease-modifying drugs. Oftentimes I find that these disease-modifying drugs don't work until you get the other disease states under control. And it's very common to see it with diabetes, lipid disorders, problems with mental health issues or sleep disorders, and maybe chronic kidney disease. So you go around the corner of these 8 disease states and you make sure that inflammation is controlled in each one while you're using that disease-modifying drug for lupus or for the rheumatoid arthritis condition or Crohn's. And you're going to get such better responses, I believe, almost universally. A blocked artery heart attack, 2 years warning, or maybe up to 7 based on the Minnesota Heart Survey. Ruptured plaque heart attack, 6 to 8 months, just based on my observational analysis in clinic patients through the years. Measuring myeloperoxidase and plaque-2 as your biomarkers of health. The blocked artery heart attack is measured by a high-definition troponin, which is a second-generation troponin level testing that picks up very small levels of troponin in the circulation. Which we've learned years ago that ischemia starts when your high-definition troponin starts to measure more than 4.5 picograms. That is your 95% cutoff for this patient. When you get to the 99% cutoff, you're at about 7.8 picograms. When you get above 10 picograms, which is what was the cutoff point of the Minnesota Heart Survey, those patients had approximately 2 to 7 years warning before they actually had the heart attack in a retrospective analysis. Let's talk about myeloperoxidase and plaque-2. Plaque-2 has been around many, many years with many, many studies, probably better than 30 plus years. Myeloperoxidase, more significant studies have come in the last 10 years, but certainly some well-founded studies. These particular markers are telling you when inflammation is building up around soft plaque, and when the numbers get higher and higher in the instance of plaque-2, when the numbers get above 235, in the case of myeloperoxidase, when the numbers get above 350, you need to start being concerned about the potential of a plaque rupture. And in my experience, usually it occurs within 6 to 8 months. Now, I have had patients with marked elevated myeloperoxidase and plaque-2 that have gone as much as 2 years before the plaque rupture, but certainly the luck's going to run out of that patient eventually. So try your very best to get this inflammation down. These are measurements of chronic inflammation. What can you do to remove inflammation chronically? Well, if you want to remove chronic inflammation, exercise is one of the most effective tools. If you get your patient exercising at least 50 minutes per day, non-stop, aerobically, getting their heart rate up to the 70% level and maintaining it, that particular patient has a good chance of removing up to 88% of the inflammatory factors for a 50-minute exercise regimen. That exercise regimen could be on an exercise bike, a treadmill, could be walking fast in the neighborhood, it could be with a hand crank. Whatever it is, don't let your patients have excuses that prevent them from getting around this exercise, because if you're going to beat cardiovascular disease, you're going to have to get your patients to become great exercise people. I explain to my patients, there's a fire in this room, there's a fire in this room, and there's a fire in that room. There's one way out. It's the door right there. If you make excuses, my leg hurts, my hip hurts, I'm busy doing something, this is inconvenient right now, I've got something going on. It doesn't matter what your excuse is. If you stay in that burning house, you're going to burn up in that house. You're going to have to get yourself up and move out of that house to that door if you expect to have success. If a patient wants success with cardiovascular disease, they're going to have to exercise, and the excuses will not get them out of the fire. How does myeloperoxidase and plaque 2 differ? Myeloperoxidase is measured plaque rupture, so is plaque 2. However, where they come from is somewhat different. They both are derived from monocytes, macrophages, but the myeloperoxidase is also released from polymorphic nuclear cells. The polymorphic nuclear cells would be in the acute phase, part of the inflammatory reaction, and therefore it's not unusual to see the myeloperoxidase climb to a higher level than the plaque 2, relatively speaking, at the time you draw the blood. If that were to happen, that would be well within what would be expected. There are some important aspects of these two inflammatory measurements that are important to be known. Having both of them side by side makes such a difference in your understanding of the chronic inflammation going on, because there is some instability to the 4 different immunoassays that we use to measure plaque 2. If plaque 2 is done correctly and the immunoassays are changed on a timely basis, temperature is controlled properly, these particular measurements can be highly accurate. However, if the lab technician does not change the reagent and the immunoassay in an adequate, timely manner, you can get false elevations of plaque 2. Now, what if you were only measuring plaque 2 and not measuring myeloperoxidase simultaneously? Very well, what you could be having is a problem with immunoassay elevation of this plaque 2 number, and you could think that your patient's about to have plaque rupture, when in actuality it's strictly a lab error. If you were measuring myeloperoxidase at the same time in that patient, you would realize this is just an immunoassay problem and not get over concerned and cause the patient fear out of a lab parameter abnormality. But when you see red in both the myeloperoxidase and the plaque 2, and it's consistent, this patient, like you see here, is in quite a bit of trouble. Please get this patient exercise. Please go through those 8 disease states and find out which ones are present in that patient. Please don't just treat those disease states, treat them from an inflammatory basis. If you aim at the right target instead of that other target people have been measuring for some years, these results are going to yield you incredible results, and your patients will greatly appreciate the fact that you saved them from having a severe catastrophe. hsCRP measurements in fibrinogen. Now, hsCRP is a measurement of this inflammatory state that's occurring in the patient. Generally speaking, it's an extremely accurate measurement of what's going on in the blood vessel as far as an inflammatory status, with the exception of the patient who has an infection or a recent trauma. So if your patient has not had a recent infection or recent trauma, you can count on this hsCRP being a very reliable measurement of what the inflammatory state is going in. I teach my patients that cardiovascular disease is an inflammatory disease state. It has to do with disease states that put inflammation into your body, like this glass appearing here, and then the things that we do to remove inflammation tie into this hsCRP. If you have more disease states putting inflammation in than you have the ability to remove out, this number is going to be greater than 1. The higher above 1 it is, the more inflammation coming into the body that it cannot be processed. The fibrinogen, on the other token, is a measurement of the day-to-day activity of what you're doing with that inflammation. How this applies: when you see a patient and you control their 8 different disease states, and now I've got a grasp of what's going on in each parameter. Now the hsCRP becomes a reliable measurement of their exercise quality, because if your exercise quality is good enough and you're controlling each of those 8 disease states from an inflammatory perspective, their exercise will remove sufficient inflammation where their hsCRP will always be below 1. Fibrinogen moves up and down quickly, and therefore, in this particular scenario, when you control the 8 disease states from an inflammatory perspective, fibrinogen now reflects exercise quantity. If your patient is exercising 7 days a week, in my experience, the fibrinogen level will always be under 390. So if a patient comes to you with a fibrinogen level of 550, and you're wondering if they've been exercising every day, you can wonder no longer. They've certainly not been, because the fibrinogen level is too high. Now you've got a means of measuring when the patient is exercising adequately enough. You've got a means of measuring when they're exercising often enough. Now, there are some patients that don't have a lot of disease states, and thus their fibrinogen level might be under 390 and their hsCRP might be under 1, and they're not exercising much at all. But that's because they have very little inflammation coming in the body. Thus, when you get a sick patient coming in, more inflammation coming in than out, you know you've got a sick patient that has inflammatory disease states. Now these measurements become extremely critical to this patient's treatment and their measurements of activity level. Now, I said earlier that approximately 84% of patients that come into your hospital emergency rooms with heart attacks have at least a portion of the reason they came with a heart attack based on insulin resistance. That insulin resistance has got to be something you're good at treating, or you'll never ever be good at beating cardiovascular disease, because this is in so many of them. I watch physicians that treat diabetes, especially in primary care circles, and quite frankly, I'm scared many of us have poor skills in diabetes, and we really need to do a makeover in this disease state. So many physicians are aiming at blood sugar, when it's not the blood sugar that's hurting the patient, but it's the inflammation related to the blood sugar. And if you don't recognize that, you're going to stop prematurely before the patient's adequately been treated and this disease process is controlled. If you don't control that inflammatory disease state from diabetes, plaque will continue to progress. Plaque rupture becomes much higher in likelihood. There are actually 4 types of diabetes. I think it would surprise you to know that prior to my doing an advanced diabetic panel, I only had 2 patients that I knew of that had type 1.5 diabetes, or LADA. I didn't have any patients with type 3 diabetes at that particular juncture. Now in my practice, it appears that I have 72 patients with type 1.5 diabetes, or latent autoimmune diabetes of adults. And we have over 377 patients that appear to have diabetes type 3. Had I not been doing advanced biomarker testing, I would never have identified these patients. What that means is the ones that had diabetes type 3, the 377 I just mentioned, they would go on one day to become Alzheimer's patients, quite possibly, because this is an insulin resistance that attacks the brain. The patients with type 1.5 that I didn't identify, they would go on to lose their pancreatic beta cell function, when in actuality